I think we'll get started now. Hello, everyone. I'm Linda Resnick, the Director of Learn, joining you from beautiful New England, where the leaves are starting to turn. I'm pleased to introduce today's presentation in our series, Using Health Systems Research to Revolutionize Rehabilitation Care. If you'd like to enable closed captioning, if you can just go back one slide, please. If you'd like to enable closed captioning, you can, thank you. You can use one of two options in the Zoom navigation bar. You can either select show captions if that's visible, or if it's not visible, you can select more to access the closed caption feature and then select options and then choose your preferred language. I'd like to say that today's webinar launches year 4 of our fall series, which is focused on engagement. You can view all of our archived presentations, including last year's webinar series. Those are shown on this slide using the link that's in the chat. Our speaker today is Dr. Gretchen Piatt, a professor in the Department of Learning Health Sciences and Health Behavior and Health Education at the University of Michigan Schools of Medicine and Public Health. She serves as the Department of Learning Health Sciences Vice Chair and Associate Chair for Education. In this role, she directs the Health Infrastructures and Learning Systems Master's and PhD program, which is an AHRQ-competency-based degree program focused on transforming health through learning health systems approaches. Dr. Piatt also serves as the co-director of the Michigan Center for Diabetes Translational Research. She has expertise in implementing, designing, and evaluating community interventions aimed at improving healthcare delivery for individuals with diabetes who are from backgrounds underrepresented in biomedical and behavioral research. She leads research teams that design and evaluate interventions for primary and secondary prevention of diabetes and its complications, including implementation and evaluation of self-management support interventions in under-resourced communities, federally qualified health centers, and primary care. Dr. Piatt has built a national and international reputation in this area over the past 15 years. We are very excited to have her share her expertise with the Learn audience. Here's the agenda for today's event. Dr. Piatt's talk will be followed by a question and answer session. We ask that you please enter your questions in the Q&A feature of Zoom so that we can address them once the talk concludes. And after the presentation, we will wrap up our time today by sharing some upcoming Learn events, funding opportunities, and a brief survey. So with that, I'm pleased to introduce Dr. Piatt's presentation, Breaking Down Learning Health Systems Silos, the Vital Role of Inclusive, Accessible, and Adaptable Teams. So Dr. Piatt, I invite you to enable your video and audio, and we look forward to your talk.
Okay. Well, thank you so much, Linda, and actually the whole team for that very kind introduction. I'm very sort of passionate about this topic, and it's a topic that I think is critical to all of us who are involved in learning health systems. So in today's webinar, I have 4 main points that I'd like to cover, and these include describing LHS scientists and the competencies in which they conduct their research. We'll then move on to talk about the use of stakeholder engagement in the context of learning communities, and we're going to review an example of forming and collaborating with the learning community in a vulnerable population. And then finally, I'd like to share with you some information about the Health Infrastructures and Learning Systems, or we call it HILS, graduate program. And we consider HILS to be one way to develop the LHS workforce. So let's go ahead and get started by describing LHS scientists and the competencies in which they conduct their research. So let's start by just sort of setting the stage, if you will, for the current state of the LHS workforce. I think, as all of you on this call are very aware, that there's this real world milieu of LHS research and the embeddedness of the researcher within the health system and engagement of stakeholders. These are all distinguishing characteristics of the field of learning health systems. But there remains challenges to growing this workforce of learning health systems. And this includes limited attention paid to the very unique attributes and skills of learning health systems researchers. Additionally, most training programs are largely focused on knowledge generation instead of being focused on the actual conduct of the research within learning health systems. So AHRQ, which many of you are aware of, the Agency for Health Research and Quality, AHRQ and others became acutely aware of these challenges around learning health systems. And they proposed two main solutions to solve these challenges. So firstly, they went ahead and defined what a learning health system scientist is. And second, they developed a set of core competencies to guide the design, the implementation, and the evaluation of training programs for LHS researchers. And I'm sure that many of you have maybe seen these competencies. I know that the webinars are largely constructed around the competencies. So this could be a review for some of you, or it could be some new info as well. But the overarching hope from AHRQ is that these competencies will guide training programs to create an expanded and a diverse LHS workforce. So let's start by just getting it out there and defining what a learning health system scientist is. So AHRQ defines this as an individual who is embedded within a health system and collaborates with its stakeholders. And I think that's probably the most important part of this definition. So they collaborate with its stakeholders to produce novel insights and evidence that can be rapidly implemented to improve the outcomes of individuals and populations and health system performance. And in order to be an LHS system scientist, individuals should have proficiency in the LHS competencies, which AHRQ also created. And the core competencies really are just the knowledge and skill sets that should be the main characteristics of training programs that LHS researchers are part of. Now, we know that many training programs aren't based on these competencies. But I think that as time goes on and the momentum around building a workforce continues to just gain more and more traction, I think we're going to see more and more of these training programs that are based in the competencies. Basically, the competencies, again, are meant to guide the design, the implementation, and the evaluation of these programs. And each competency has associated learning objectives that really describe the educational and experiential approaches for achieving it. And we're going to get into that a little bit later on in the talk, especially when we talk about the health infrastructures and learning systems, PhD and master's programs, and their educational and experiential learning approaches that we use. So for some of you, again, this is probably review, but for others, you may not have actually seen the competencies before. Basically, there are 8 domains and 38 associated competencies. And the domains you could see here on the screen include research methods, system science, research questions and evidence, informatics, ethics, improvement, implementation science, equity and justice, and lastly, engagement and leadership. And it's in this last domain, engagement and leadership, that I really want to focus on today and provide some examples around. So, the engagement, leadership, and research management domain is aimed at engaging stakeholders in all aspects of the research process, and then to effectively lead and manage LHS research teams and projects. And when you break this domain down into its competencies, you could see some main themes running through this list of competencies here on the screen. Diversity, translation, dissemination, effective team-based project management, patient and clinician engagement, and then lastly, vulnerable populations. So I want to take this domain and begin to unpack it a little bit by providing you with some tangible action steps to sort of engage stakeholders in the research process and to take this to the next level in terms of being proficient in this particular domain. So engagement within a learning health system requires this unique set of skills and knowledge due to the very diverse nature of the folks in which we work. That becomes even more important when we sort of branch out of the health system and perhaps work in the community in some way, shape, or form. The complexity of the healthcare system and of the community really does require us to learn how to proficiently engage other stakeholders. We should really be engaging them in all aspects of the research process, recognizing their unique perspectives, their unique experiences, and the skills of each stakeholder group in helping to achieve study outcomes and improving outcomes, and distributing new knowledge and effective communication on the implications of that knowledge across the groups and to the public at large. And that's really where we sort of get into dissemination science and all of the intricacies of how to properly or adequately disseminate knowledge out into the public. So let's switch gears a minute, or not switch gears, but actually just transition to talk a little bit in more detail about stakeholder engagement in the context of learning communities. So in the context of learning health systems, we often hear about learning communities. And in fact, the learning community is often considered the cornerstone of the learning health system. But basically, learning communities are just a group of stakeholders who come together and they're able to reflect and share judgments and concerns and uncertainties about the proposed research and discuss ideas to collectively improve any type of health problem of interest. And it's really through these interactions that you, as a LHS researcher, you start to build that trust, and you start to build skills and agency among your stakeholders that you're working with. And there's quite a bit of evidence that demonstrates the benefit of stakeholder engagement and partnerships in research and practice. And I think that this is me really preaching to the choir on this particular topic, but meaningful partnerships really do help you to better understand your community in the broadest sense of the word, and its strengths and weaknesses and assets and culture, leaders and readiness for making changes. In fact, there's an increased likelihood that an intervention will be adopted and sustained if these partnerships are in place from the very beginning of the project, and even before that, like before the project even gets off the ground. Involving the stakeholders is actually pretty critical. So not only do these partnerships and not only do they increase the likelihood of an intervention being adopted and sustained, but they also are known to ensure quality and practicality of your efforts and are one of the most essential tools in helping to disseminate findings when you get to that point. There's, you know, if you read the dissemination literature, there's really no better way to disseminate your work than to have a really strong group of stakeholders helping in that effort. So when you are beginning the process of identifying and partnering with potential stakeholders, there's some critical questions you'll want to ask yourself to ensure that you really are assembling the ideal group. And these include asking yourself things like, what do you want to achieve with your work? Do you want to inform and build awareness of your work? Do you want to understand your stakeholders and get their input? Do you want them involved in the decision-making process? And these two questions often make people pause a little bit, especially those of us who are researchers and who are accustomed to being the person in charge. Because in a sense, you're giving up a little bit of your independence, so to speak, to rely on others in that decision-making process. But what we know from scads of evidence is that there is a dose-response relationship with stakeholder involvement and successful interventions. The more they're involved, the more successful the project will be. And we see that over and over again. But the question remains, how? So how would you go about identifying and assessing who your stakeholders are and how to engage them? And when I conduct my own research, I sort of go through the process of stakeholder engagement and by thinking through like this 2x2 table that you see here. And I sort of visualize the level of interest on the x-axis and their level of influence on the y-axis. And doing that breaks up the table into 4 separate components. So basically, stakeholders with low levels of interest and low levels of influence are still stakeholders, but you may not have to put as much effort into that group of folks. These are individuals who may work in your space, but maybe aren't involved in your work or have the same interests as you do. Moving up 1 block to the keep happy area, many times the people who fall in here are your sort of high-level administrators. And these are folks in your organization that can make things happen, but they may not have a ton of interest in the work that you're proposing. But in this case, it's best to focus on keeping them happy. And then when we head down to this area of the table in the keep informed section, this is where we tend to see people with very high levels of interest in the topic that you're working on, but they may not have much influence. And a lot of times, this is where patients, family members, caregivers often fall. And then finally, when we move up to the top right-hand corner, these are our key influencers. And these are folks with high levels of influence, high levels of interest in the topic. So for example, if you were doing some type of project where you were implementing a best practice alert into an EHR, chances are the health IT team is going to be one of your key influencers. So I like this table. It's a way to really put some structure around how to figure out who your stakeholders are and then how to work with them moving forward. I think the main thing is that even if folks are low effort, they're still stakeholders, and you still have to pay attention to some, to their issues that are coming up. So with that, let's move on to an example of learning and collaborating with a learning community of stakeholders in vulnerable populations. And this is an example of a research study that took place in 4 communities in Metro Detroit, which, as you might expect, can be quite vulnerable. So like I mentioned at the start of the talk, I'm a diabetes researcher, and more specifically, my research is focused on implementing evidence-based solutions for diabetes self-management support in community and health system settings. And at Michigan, we have a very long history of working in the African American communities in Detroit. And over the years, we have formed very strong ties to different community organizations in those areas. So in the case of the Praise Diabetes Project, the community organizations who we were working with were churches, and they were African American churches. And we formed a learning community with 40 plus stakeholders that included research staff, diabetes educators, nurses, peer leaders, church personnel, patients, and others. And we brought them together to talk about how diabetes self-management support is needed in their communities and in the long term. But what we know about these communities is that the local hospitals in these areas don't offer those services. And on top of that, the group's consensus was that they didn't want to go to the doctor's office to get these services. They didn't want to go to the local hospital to get these services. They wanted it to be delivered in a place where they were comfortable and where they were among their friends. And that was how the Praise Diabetes Project sort of came to life in these African American churches. So the study was a 33-month cluster randomized hybrid type 2 implementation trial. It was conducted in 4 phases, starting out with planning and qualitative work, which was when we worked a ton with the learning community. From there, we moved into phase 2, which was the trial. And then phases 3 and 4 included post-trial qualitative interviews and cost effectiveness and simulation analysis. But for the purposes of the talk right now, I'm just going to focus on the trial part of the Praise Diabetes Project. So the study design that we used here was a modified stepped wedge randomized controlled trial. It took us outreaching to 261 African American churches in the study area in order to get 21 churches enrolled. And once they were enrolled, they were randomized to one of 3 diabetes self-management support arms that you could see there on the screen. All participants began the study with 6 months of usual care, and then that was followed by diabetes education for 3 months, diabetes self-management support for an additional 12 months. And then the very final 12 months of the study was focused on us as a research team stepping back and sort of observing how the churches were able to continue to sustain these efforts in their communities out into the long term. And this was actually, it was this phase right here, this ongoing support, that was probably the most interesting part of the study from a methodological standpoint. To get us back to thinking about stakeholders, in each of the 21 churches, there were several influential stakeholders who were critical to the success of the study. These included members of each church's health ministry. It included a parish nurse who was part of each church. It included peer leaders who were members of that church's congregation. And then it included the patient participants who were very involved. Just quickly, these were the different approaches that we used. Basically, these were our implementation strategies, and we were testing which approach to self-management support was the most effective. Whether it took a parish nurse plus a peer leader versus just a parish nurse to do it versus just a peer leader doing it. And the primary outcome that we were most interested in this case was sustainability of improvements in glycemic control and diabetes distress. But before the nurses and the peer leaders could begin to implement the services, they had to be trained to facilitate diabetes self-management support. And in total, we trained 31 peer leaders and 16 parish nurses with a curriculum that we developed here at the University of Michigan that is based in the empowerment approach to diabetes education. I think the best way to describe that curriculum is that, unlike some other training programs that focus a lot on training peer leaders and others to understand diabetes and to understand diabetes content, we trained them on how to facilitate groups. And that was from sort of just years of doing this type of work. We came to understand that was where the training was needed. It wasn't necessarily about, hey, what insulin should I ask my doctor to give me? So our participants in the study were on average 64 years old. The majority were female. Over 70% of the participants had attended at least some college, and a little over a third were using insulin. This was a fairly obese population, with 71% having BMIs over 30. So clinically, over half of the population was struggling with glycemic control, and about 40% had hypertension. This is fairly common in what we see with folks from minoritized communities who have diabetes. When we examined diabetes distress levels, 23% of the population reported moderate levels of distress about their diabetes. And when I talk about distress, I'm talking about things like feeling anxiety and stress over the regimen of having to check their blood sugar, feeling distress over not liking their provider, things like that. So 23% of the population reported moderate levels of distress, while 16.4% reported severe diabetes distress. And I can say that the moderate and severe diabetes distress levels are clinically relevant. So these are the main results of the study. And as you could see here, glycemic control and diabetes distress improved, and then it was sustained over time. And while it's difficult to pinpoint exactly what led to the sustained improvements, I attribute it largely to the peer leaders and parish nurses who were those key influential stakeholders who continued to provide support to our participants during this time frame. And the other sort of zinger to throw in there was that this was also when COVID began. So it was right during this ongoing support period when we sort of, got locked down, and Detroit became a hotspot, so to speak, for COVID. So I really do attribute the success of this study largely to the parish nurses and to the peer leaders. So you might be asking yourself, okay, this is great. The findings from the study, facilitated understanding of barriers and facilitators to implementing self-management support, and how to design effective approaches, and even the long-term impact of providing self-management support. But who on earth are the people who actually do this type of work? And I think probably a lot of you are, and I am, but we weren't necessarily trained as a learning health sciences or learning health systems workforce. And given that, are there training programs out there who, where people can get trained to do this type of work, and become proficient in those competencies? And the answer is yes. There are training programs out there. So I just want to finish up my talk for today with providing an understanding, an example of some opportunities to build the LHS workforce. One such program that's sort of moving the needle on building this workforce is the Health Infrastructures and Learning Systems, or HILS, as we call it, degree programs at the University of Michigan. And these live in our Department of Learning Health Sciences. HILS was and is the only graduate program of its kind in the United States. It was developed in 2015 and matriculated its first cohort of students in 2016. There are training programs out there that are for postdocs, but this, to our knowledge anyway, we continue to be the only program that's training pre-docs in learning health systems. HILS has an LHS competency-based curriculum that includes both didactic and experiential learning. So students are all required to complete, we call it a learning cycle project, but you can think of it as a practicum. HILS provides this sort of synergistic combination of courses in data and information sciences, in infrastructure, and in behavioral, social, and systems science. And really the emphasis on the science of infrastructure, it sort of highlights the importance of enabling change that is both sustainable and scalable. And that's why we were sort of just very married to the fact of working infrastructure into the name of the degree program when we created it. So as I mentioned, the program is grounded in the AHRQ competencies, focused on a culture of continuous learning. Students are gathering and applying evidence in real time to guide care. We focus a lot of the classes on employing technology methods to improve decision-making, on promoting the inclusion of patients and patient-centered outcomes research, capturing and analyzing data and care experiences, and just continually assessing outcomes to refine process and training in order to create feedback cycles for learning and improvement. And this table is just simply a matrix of the HILS curriculum mapped on to the AHRQ competencies, and also mapped on to the learning health cycle, where you could see here the performance to data element, the data to knowledge element, and the knowledge to performance element. So you could see that the competencies are along the top, and the courses and elements of the learning health cycle are along the left-hand side there in the rows. And all HILS courses are mapped to at least one competency area. There's 3 HILS degree options for folks who are interested. We do offer a residential PhD. That's a very sort of typical traditional PhD program, 36 credit hours, an experiential learning experience, qualifying exam, lit review, prospectus, and completed dissertation. Our average time to degree is around 4.5 to 5 years in the PhD. We also offer a residential and an online master's degree in health infrastructures and learning systems. The really nice part about it is that the courses are very, very similar, if not identical, to the PhD program. Students in these programs also get the experiential learning experience, and if people decide to do it full time, it can be completed in 12 months. So just to conclude, while the HILS program may be the first of its kind, and to our knowledge, like I said, the only pre-doctoral program out there in learning health systems, programs that train LHS researchers are gaining momentum and will undoubtedly continue to gain momentum into the future if we're to even come close to having enough learning health system scientists to meet the needs for the field. And what I have come to know and realize over time is that this new generation of diverse transdisciplinary LHS scientists with a focus on application and mastery of the skills and content knowledge outlined across those competencies, and who are driven by LHS core values, are really the folks who will be trained to bridge the disciplines that you see here on the screen, and they're probably the most important catalyst for the future of learning health system research as we go forward. And with that, I thank you, and I am happy to field any questions that you might have.
Super. Thank you so much for that talk. I really enjoyed hearing more about your work and about the PRAISE program and about the HILS program. I know, folks, you can ask your questions in the Q&A feature of Zoom, but I'm not seeing questions yet, so I have a few of my own I'd like to start with. First, one of the things that you didn't speak about, but I think we're all interested in, is when you engage stakeholders, how are they compensated for this? The topic of compensation came up at the Corey conference last week, and what amount and type of compensation is appropriate, and what did you do in the PRAISE study?
Really, really good question, and an important one. In the PRAISE study, we did compensate them, like the peer leaders and the parish nurses. We compensated them with stipends. And in hindsight, if I was to do it all over again, I would have actually employed them as employees of the university. And I say that for two reasons. One, we would have been able to pay them a lot more. And that those payments would have been, there would have been some, I don't know what the right word is. They would have gotten paid on an ongoing basis over time, rather than getting stipends at certain points of the study in which they accomplished things. So how we did it in PRAISE was, okay, they completed their training, they got a stipend. They did such and such activities with the participants, they got a stipend. I think when we think about sort of infrastructure to engage stakeholders, we really need to think about capitalizing on the infrastructure that we have all around us as the researchers. What was the second part of your question?
I was like, how much did you pay them, and how was that done? Yeah.
In PRAISE, we paid the peer leaders and the parish nurses $600 at various time points throughout the study. Maybe like 3 or 4 different time points. The issue is that when you do a study that's that long, that's like they're investing a lot of time. And I could say that similar to probably what you heard at the PCORI meeting, in terms of the work in learning health systems, I mean, there is movement toward really incorporating sort of patient partnered scientists into study teams where they will be paid just like we're all paid, because they're spending just as much time on this stuff as we are. So I'm hopeful that as the field moves forward, we will continue to sort of bring more patient partnered scientists onto teams and be able to pay them in a more structured way.
Hmm. There's a follow-up question to me in the chat from Lisa Jeckett. She's curious, have you ever used non-monetary sources of compensation like childcare, housing, transportation, other non-monetary sources of?
We did. So in the PRAISE study, we did pay for, we paid for transportation. We, if there was a childcare need, we were able to provide that for them. Those items, while they were very important and they were appreciated, I don't think go as far as, hey, here's your paycheck, for doing all of this work. One of the things that we struggled with in the PRAISE study was that we had attrition with the peer leaders and the parish nurses, because it was a long study. Like, that was, I think, one of the very first times that those folks were involved in a study that was like, over 3 years long. And it was all great at the beginning and people were really jazzed up about it, and we're so thankful and all of that kind of stuff. But 3 years down the road, it's like, oh, you're still here? Like, you still want me to do what? So yeah, I absolutely would, if I had to do it again, I would absolutely hire them as employees.
So on a related question, how do you suggest keeping participating stakeholders engaged throughout? Short of employing them, because I think this is a challenge I've had in some of my trials where I involve clinical teams at different sites, and then the project bleeds on longer than you expected, and they're like, how to keep people continually engaged and invested. What are some of your suggestions?
Yeah, it's a great question, and it's a big challenge. I mean, and I would be the first person to admit that. We work with, this is separate from the PRAISE work, but I work with a federally qualified health center in Detroit, and they are just awesome about continuing to be engaged for years and years and years now. And I think probably the best way to keep those folks engaged and continuing to come back is to make sure that they understand that they have a say in the work that's being done, and that their voices are heard. I think that so often we as researchers, we want things done a certain way. We think we know what's best, and we don't. We don't live in those communities, and if we do, we're not part of whatever group is gathering. But I would say in that federally qualified health center that I work with, it is truly a collaboration where the folks who work there have just as much skin in the game as we do. And I think that's what keeps them coming back. They get publications, They are happy when new grants come in. Yeah, so that would be my answer to that. Just making sure that their voices are heard.
Before I get to a couple of the questions in the Q&A, I want to remind the audience that there is a evaluation link in the chat. So we want you to make sure that you have a chance to save that link and complete the evaluation for this event. So from the chat, there's a question from Maricruz Moya saying, thank you for your presentation. How did the research navigate the turnover of stakeholders during the long-term engagement plan of 33 months? So you mentioned that stakeholder. So I imagine that involved retraining did you have to repeat the curriculum for teaching facilitation? How did you do it?
Oh, yes. We didn't have much choice. We had to repeat the training, and we had to always be on the lookout for more people to engage. Like I said, the sort of zinger also in there, like not only was it 33 months long, but the zinger was COVID. And sort of what happened in that time frame, is just like with all of us, everything turned to Zoom. And that posed big challenges for our parish nurses and our peer leaders because they had not used Zoom before. So, we really did have to spend a lot of time with them. And there was a continuum of knowledge with how to use Zoom and how to conduct the groups via Zoom. Anywhere from, oh yeah, I got this, no problem, to what's a pound sign, on the phone. So it was, it's a very, I would say, when you're doing this type of work, it's a very high touch endeavor that you're setting out on. It's not going to be a, hey, you're my peer leaders and parish nurses and other stakeholders here, go ahead and do it.
So how much, given that the high touch nature of it, how and the size of your studies, like, can you talk about your team? Who else is on your team? Is that high touch from you, or is it from a project coordinator? How does that work?
Yeah, so I was the PI of that, and then we had a study coordinator who was funded at 100%. We had 3 diabetes educators at different levels of funding, but yeah, three diabetes educators who also functioned as kind of like coordinators, maybe not as detailed as a study coordinator, but and then we had the folks who were focused on the end product. So all of the data work that had to be, data had to be cleaned and all of that type of stuff. We also had other co-investigators who were part of the study team, like, the co-investigators who were leading the qualitative work, the folks who were doing the cost analysis.
I see.
But
Okay.
it was really that core team of the study coordinator, 3 diabetes educators, and myself, who, we were going to the community. We were, it was just a high touch type of endeavor.
Right. I want to shift over to ask you a little bit more about the HILLS program. Peter Wang asks if you could elaborate on the infrastructure aspect within HILLS. Does it primarily refer to health IT infrastructure, such as data center or cloud computing, or something else?
It's when we talk about infrastructure, we talk about infrastructure in its broadest term. So yes, it's all of those things that the person mentioned, but it's also people as infrastructure. It's policy as infrastructure. So we teach two courses in health infrastructures, health infrastructures 1 and health infrastructures 2. And we start out the first health infrastructures course with just getting people to think about the physical infrastructure, like, you know, when to build a bridge, so to speak. And as time goes on in that course, different elements of infrastructure are introduced, and people being one of them. And by the time that students get to the second infrastructures class, that's actually the PhD capstone. They're able to understand how physical infrastructure, people-based infrastructure, policy infrastructure sort of have to come together in order to facilitate that learning cycle.
I see. Yeah, I was really struck by your comments about the distinctions between competencies for learning health systems researchers, really involving more the conduct of research and not so much a focus on the generation of research. And so I have a question. At Learn, we're really interested in providing opportunities for scientists to acquire these skills. And I'm curious about your practicum programs in your HILS program. Are they conducted within a single health system, or are they can they occur anywhere? And how does that work?
So they can occur anywhere. It makes it difficult for us as the administrative team. I will say that a lot of the projects happen here at Michigan Medicine. But for students who are sort of very vested in working with, like social determinants of health or working in vulnerable populations, they will do their projects at different health systems, or in community organizations. We had a student do his, we have a network of federally qualified health centers for the entire state of Michigan. And his practicum was focused on understanding how to link behavioral and mental health services into the existing EHRs in these clinics. So those are the, sort of like types of projects. We've had, for students who have done their projects here in Michigan Medicine, we had one student who was already working in the perioperative environment, do his practicum around understanding why instruments were being left in the cavity during surgeries. And it turned out that it was all because of the culture of the OR, and nurses didn't want to speak up and say, hold it a minute, we need to count these instruments. So just a ton of different interesting projects. We've also had folks work with our physical medicine and rehab department and work closely with Claire Kalpachian and others there. We have had 2 occupational therapists come through our PhD program. So there's that connection.
So I'm curious, and this is something I know a lot of our audience may struggle with, is what is the distinction between research, education, and quality improvement in terms of, and how do you straddle those distinctions in your training programs, and also, I mean, for those of us who aren't in the audience members who aren't in training programs but are trying to do some of this work, when do you need to go to the IRB? And
it's an issue. I mean, it really is. We've had people from our quality department here say to us or the chair or whoever, aren't you just doing quality improvement in that department? And I guess our response is no. Well, that's obviously the response, But the reasoning behind it is like we conceptualize learning health systems research as the science of it, the science of why the improvements are made and how are the improvements are how are they made. I think with quality improvement, number one, it's usually local. So it's, your local health system, that's where that's happening. But two, to my knowledge anyway, there's not a lot of figuring out how the improvements are made. It's just that we want to make these improvements and this is how we're going to do it. But we don't know how they get made or why they're made. So I think there's less maybe sort of scientific methods around QI, and more scientific methods around learning health systems work, from acquiring the data and identifying where the gaps are, to analyzing the data in many, many different ways, whether that's traditional analyses, whether that's AI and machine learning, to creating new knowledge, and then implementing and studying the implementation of that knowledge into practice.
So from what you're saying, I would assume then, like, do most of the practicum projects require then IRB approval or exemption?
Yes, we get an exemption for all of them, just in case.
Okay. Yeah, that makes sense. It's just something I know a lot of people, it adds a lot of time and complexity. I do have another question. I want to go back to the beginning of your talk. I was fascinated by your grid that had the level of interest versus the level of influence.
Yeah.
Is that something that when you're looking at your stakeholder engagement that you identify a priority where you think people will fit, because you don't totally know? For some people, you might think they're going to be greatly engaged, but they're not. When do you work that?
I mean, I would say it has to be fluid, but ideally, I would want to have some idea beforehand, at least some idea, and then I think as you start projects and you're working with stakeholders, you're able to get a better sense of, oh, maybe this person doesn't have as much influence as I thought they did, or maybe these folks aren't as interested as I thought they would be. But yeah, I would say, and obviously all of this stuff is so in the gray area, it's not black and white. And there's so much fluidity around it. So I would say, yes, ideally, I would start ahead of time. But probably realistically, most people start it when the study starts. And I think that's where we tend to get into a little bit of trouble.
Well, thank you. Yeah, this is really interesting. I'm not seeing any more questions in the Q&A, so you have another minute, folks, to ask a question. If you haven't yet completed your evaluation or gotten hold of the link, please do so. So I'm not seeing any further questions, but I really want to thank you so much for sharing your expertise with us. And I do want to point out for those in the audience that we have a few additional events coming up, so you can join us October 25th for our grand rounds from Stephen Hunter. It Takes a Village, team-based clinical research within a learning health system. We also want to have you look for our November webinar events, which will be Dr. Kristen Rosengren and Dr. Pimjai Sudaswed on focusing on knowledge translation and strategic communications. So please register for those. We have an open funding opportunity for our Learning Health System Scholar Program. We have an informational webinar that's been archived that tells you more about that program. Our request for applications is now open with a letter of intent due October 31st. We also have a frequently asked questions page about our Scholars Program. This is a one-year commitment to form a relationship with a health system partner to begin the process of becoming an embedded scientist and grow your skills. The link to the Scholar page is in the chat, or will be placed in the chat. And also, I want to tell you, we have released season 3 of our podcast series. These are the podcasts from our webinar series. So we encourage you to subscribe and listen to us on the go on Podbeam or Spotify. The link to our podcast series in the chat. And lastly, I want to invite you to explore Learn's applied learning cases. We have a couple of new ones in addition to the ones that we've had up for a little while. These cases are organized by major competency research domains from the AHRQ competencies, and each case includes a description of the case, a video presentation, curated resources, and links to our Learn's resource database. So please check them out. There's also a link to that in the chat. So I'd like to once again extend a sincere thank you to Dr. Piatt for sharing her time and expertise with us, and thank you all as well for attending and sending along your questions and comments, and we'll see you next time. Thank you so much.
Bye-bye. Thank you.
Bye.